Thank you for joining us for this special series of This is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health, and Humanities. Welcome to This is Getting Old. Today we're continuing our special series on the Age Friendly Health Systems Initiative and the 4M's framework, specifically talking about mentation. And when we use the term mentation, we're talking about preventing, identifying, treating, and appropriately managing what we refer to as the 3Ds in geriatrics. So that's dementia, delirium, and depression. Today I'm joined by Dr. Tahira Lodhi. Welcome back. And before we begin, maybe you can just introduce yourself.
Hi, I'm Tahira Lodhi. I'm one of the geriatrics and palliative care physicians with George Washington University. I've been working in this capacity for the last 9 years, and I work with trainees at different levels, from medical students to residents to fellows. And this is bread and butter geriatrics.
Okay, well, thank you for being with me today. So, like I said, the 3Ds are the cornerstone of geriatric care. You call it the bread and butter. And I think the most difficult thing is kind of teasing these things apart. So maybe you can just give us some basic information about what makes them similar, what makes them different, and then we'll go into each one individually.
Right. So the basic thing about trying to tease these 3Ds apart is knowing the baseline. So getting that collateral history, if possible, from the patient, and if not, a caregiver, a family member who knows the patient, knows what the baseline mentation is, and then taking it from there, depending on what situation you're in or what situation you receive the patient, whether it's outpatient, in the long-term care setting, in an emergency room, or in you're seeing the patient admitted to the hospital. So the 3Ds would vary in presentation, and sometimes it's very difficult to tell them apart. They may coexist, all of them. It's a challenge diagnosing them, but it's very important that we recognize them and sort of work through our tools to see which one is at work in a particular situation.
True. And then all the, the history, knowing someone's social history, making sure that we've done lab work, that also helps to tease out. I have done a podcast on how dementia is diagnosed, or in the other term that dementia that we hear most often is Alzheimer's. So just to clarify kind of what that term dementia means. So, and thinking about when these symptoms started and how long they've lasted. I think in my mind, those are the things that help us the most in trying to figure them out. So let's talk about recognizing depression.
So recognizing depression, of course, you will start with the history, start with the particular circumstance that the patient is in. You would go through the symptoms of depression, but then we have tools that can help us. PHQ-2 is a very short, easy to administer, less than 2 minutes tool that is used across all settings. And then PHQ-9 is another tool that we can use to assess whether the patient has depression. For my dementia patients, I feel like geriatric depression scale, GDS, helps me better. But using these tools to, first of all, diagnose depression. And then the thought process to keep in mind would be, what's the onset like? Is there a long-standing history? Is the patient already on medications? Do I need to start medication, or do I go to a psychological evaluation at this point, or get a psychologist to talk to the patient at this point? Cognitive behavioral therapy is maybe a better answer at this point. So making sure you, first of all, diagnose it appropriately, and then start treatment as soon as possible.
Right. So if a family member is interacting with, their loved one, and they're trying, what would some of the symptoms be that they should look for? Really, like, I know in my practice, the number one question was like, are you feeling sad and blue? But it's not like you kind of walk around, some people will tell you how they're feeling, but
Right.
it can look like they're having memory problems, and that's really not what's going on. So, I, I had one patient one time, did a very lengthy interview with her social history. Her husband had passed away like in the past 6 months, and her clock drawing, which is where you put the numbers on the clock and you have to make the hand say 10 and 2. Well, her clock drawing was like all over the place. And I was like, but I still feel like that's what it is. And so we did start her on an SSRI, and she came back 6 weeks later and her clock drawing was perfect. And it was
Right.
just, that's how badly depression impacts the brain, when you're older. So there are
Right.
other things that you mentioned, cognitive behavioral therapy, putting someone on medication. Um, Anything else?
Right. So, like we said before, these 3Ds can superimpose on each other and just mask each other, basically. So, it's very much possible that your patient comes to you with altered mental status, and
Mhm.
all you probably would get on history is mom or dad or grandpa is not themselves. That's not them. They are usually very interactive and eat well, sleep well, and now all of that is disturbed. You may just suddenly find a person who was very interactive with the activities and in a long-term care setting, and now they're sitting to the side, not talking to anybody, and then just feeling down. That's the time to evaluate that person, to make sure it's not depression. If there is a loss of loved one recently, especially in this COVID situation that we are in, any altered mental status like that warrants an evaluation for depression. And treatment wise, we know that SSRIs are as effective as behavioral therapies. So we should evaluate our patients, and depending on the resources we have in the community, which, as you know, is a challenge, to find a psychologist who can come and talk to your patient, or where you can send a patient to. That's a decision that you have to make, depending on the level of depression and how much it's impairing the person's daily life.
True. And that's actually a really good segue to talking about delirium. And this is also kind of illustrates the point that we're making, that they're difficult to tease out. But with
Right.
delirium, I would get a note from one of the nurses that says, so and so's just not right today. I guess that's how we say it in the South. It's like, okay. So if someone says, they're just not right today, they were fine yesterday, talk to me a little bit about, delirium and how you recognize that.
Right. And again, this can present as altered mental status. That's all we find out in the inpatient settings or anywhere, basically. And the etiology is vast. Any number of things can result in acute change in mental status. Depression can present like that, but it present more in a subacute sort of fashion, as opposed to delirium, which last night the person was okay, or this morning my patient was okay, and suddenly a change in mental status was noticed. And so that's the hallmark, acute change in mental status, and then it's waxing and waning. The person is fine for a few minutes, and then during the conversation the mental status changes. So it can be a medical urgency. It's rarely an emergency, could be, but most of the time it's important that we recognize it urgently, because the underlying condition might be an infection, might be an electrolyte abnormality, might be a medication, any number of things. For our older patients, it could be constipation. I've had a lot of patients, a commonly overlooked condition. You tease through the history and you find the person has not had a bowel movement in 3 days, and that would result in altered mental status. So very important to recognize it. Another hallmark of delirium is inattention. In addition to the waxing and waning mental status and acute changes in mental status, when you find inattention, you lean more towards delirium rather than depression or dementia. Um, It can get tricky, especially when when delirium is superimposed on dementia. But it's important to recognize because it is reversible in many cases.
Right. And so that's another hallmark of delirium, that it is reversible, because versus depression is treatable, and with dementia it's not reversible, and that's going to be the trajectory. But there are also two different types of delirium, and you mentioned constipation. So I equate hypoactive delirium to constipation because it doesn't typically get people's attention. The older adult is just sleeping, versus hyperactive, when they're trying to pull out all their IVs and climb out of the bed. That's like diarrhea. Diarrhea gets people's attention. And so does hyperactive delirium. And you mentioned, just recognizing it is the biggest thing. I think, some of the studies that I've seen, up to 60 to 75% of healthcare providers don't recognize delirium. So that's why it's important for families. And you mentioned knowing that person's baseline status. That's particularly important if someone's going to be having elective surgery.
Right. So post-op delirium is a very commonly found entity. Important to recognize. The issue with delirium is, it's associated with higher morbidity and mortality even. We can prevent delirium, and we should make all the efforts to prevent delirium as much as we can, because once it's onset, we really don't have too much in way of treatment modalities that can alter the course. We can work on, making sure the vision is good, and exposure to sunlight, and maintaining circadian rhythms as much as we can, reverse constipation or diarrhea, or treat underlying infection or electrolyte abnormalities, or many other things. But once delirium is onset, the course is difficult to alter. It can last for as long as months. Up to 6 months has been recognized in the literature. So it's very important to prevent delirium from happening. Make sure hydration is maintained, make sure medications are aligned and reconciled, and avoid medications that can precipitate delirium. Look at the Beers criteria, as we mentioned in another podcast we did, so that we can prevent the onset of delirium.
And so then, what are some of the screening tools that a provider might use?
So confusion assessment method, CAM, is one of the tools that can be used for delirium. And again, it's the inattention part that really gives it away. It has several subparts, if you will, that can be used in the ICU settings, in the medical surgical units, and in the emergency departments. When we are training residents and students, we make sure that they are comfortable in using these tools in the different settings.
Right. So I'll also hyperlink in the blog article. There's like a checklist if you are going to have surgery, that families and older adults need to look at and understand. And we can also try to link to a version of the confusion assessment method also. Mm-hmm. So now let's talk about dementia. And again, the term most people are familiar with is Alzheimer's disease, but there are, like 70 different types of dementia. Alzheimer's is just the most common. So what are some things that you would look for if you thought someone was beginning to have memory problems?
Right. So a lot of times, again, the complaint would be, my mother is not being herself, or my loved one is not being themselves. Their mental status has changed from baseline. So again, it's very important to know the baseline. Unfortunately, in dementia, that's missed, especially when caregivers, when patients are living on their own, or when one spouse dies, and then we recognize, oh, this person had dementia, and it was just masked because the other spouse had taken over whatever the deficiencies my patient had. So
and the term for that is splinting. You know, so I've
Right,
always told
right.
someone, I was like, you know, if one of them has the brains and the other one has the brawn, they're good because they
Yeah,
splint each other.
yeah.
But if the brain goes or the brawn goes,
That's when we
like,
recognize, even as providers, even when I've known patients for very long and they splint each other so well, they are able to mask it even in my office settings. And then I later find out, oh, but the splinter is now no longer available, and these are the deficiencies my patient really has. So it's very important to screen for dementia using screening tools that are available to us. As you know, MMSE is copyrighted, and we unless we buy it, it's not available to us. MoCA, Montreal Cognitive Assessment, is what I use most commonly, and LUMS. There are others available. The thing to keep in mind about these screening tools is they are screening tools. They don't diagnose dementia. So again, other tools that we rely on, history is our biggest tool.
right,
That caregiver information has a big role to play in diagnosing dementia. It's very important to recognize the difference between mild cognitive impairment versus dementia. Again, because medications largely don't have a role in mild cognitive impairment as opposed to dementia, except for a very small subset of patients. And again, the course varies according to different types of dementias, the individual patient, and so you really have to look at your whole patient and do a full biopsychosocial evaluation in order to be able to diagnose dementia. And typically we say it's dementia when the memory issues have progressed to a level where they are interfering with activities of daily living. Bathing and dressing are two very sensitive ADLs that are, when they are affected, we know the onset of debility is imminent. So
right.
it's very
Well, actually,
important to do that evaluation.
right. And those are actually late to look at the ADLs. I mean,
Right.
where families are going to see it first are in the IADLs, which is money management, meal preparation, being able to plan and execute an event. So those are the types of things that caregivers can let us know about, that are changing, or people that withdraw. They just stop going out and interacting with people, and it's because they're afraid that someone's going to find out that they have a
Mhm.
memory problem. And that's typically why it's really more moderate to late, when they begin to have, the ADLs.
Right.
That's often when it's brought to the provider's attention, because they just don't want to report it. But the sooner you report it, the better off we can help to intervene. And the medications that we have right now, they're not going to cure it or reverse it, but they slow down that progressive loss of functional ability.
And what I tell patients and families typically about medications is, I'm not looking to a reversal in the memory loss. What I'm looking for, clinical effect of the medications, is the person being more in the moment, be able to carry on conversations, be able to concentrate more on the subject that we're talking about. That's what medications do. And to keep in mind that there is a time for these medications to work, a timeline.
Right.
When you see a person being on a maximum dose of the medication and the memory is still declining, that medication is probably not working.
Right.
It's time to think about stopping the medication, because again, it can affect kidneys, the way it's being metabolized, and the pill burden that it carries. It probably doesn't have a role anymore.
Correct. So again, this is something, that people just need to be aware of and to report to their provider as soon as possible. I know in 2018, the Bold Alzheimer's Act was passed, and that is going to engage all of the public health departments in the United States to roll out the CDC's Healthy Brain Roadmap. But it's to help with earlier detection, provider education, patient education. So let's talk a little bit more about things that people can do or should do if they have been diagnosed with Alzheimer's or dementia.
Right. So medications, as we said, have a role, but it's a limited role in dementia. The supportive care, the caregiver burden that it carries are real things. Supportive care in terms of, depending on the patient's limitations, whether like you said, it's IADLs that are affected, activities that help patients live independently in the community. Supportive measures to put in place for that would be, somebody to help shop, grocery shopping, help with paying bills, who is going to be the power of attorney in case, the patient cannot make medical decisions for themselves. Those are the type of things, some of the things that we as providers can help set up for our patients. So again, to your point, it's very important for us to recognize those limitations as early as possible, so we can again set up the supportive care in reference to the what matters part of the 4M's that we were talking about. It's very important for us to know what matters to the patients, who are the people they identify as people who can carry on their wishes in terms of their whole plan of care and towards the end of life. That this is the time to discuss as providers, to discuss with our patients, provide them with functional enhancements and supports in terms of fall prevention strategies inside the house, outside, putting measures outside of the house to maintain safety as much as possible, address the advanced directive, and of course make sure we reconcile medications on every visit.
Right. And yeah, and for caregivers to begin to look for support and training, because Alzheimer's disease is brain failure. And so each interaction and each day you could be, you as a caregiver, you have to learn how to live in the moment also. And there's a lot of grief that goes into this, anticipatory grief. So caregivers just need to, begin to look for resources to help them learn how to cope, because it is stressful. And we also need to let them know, that the caregiver is going to need support. You can't just be one person. If the burden's on that one person, a lot of times the caregiver dies for the person with Alzheimer's disease does, because the person with Alzheimer's just living in the moment. So they're not stressed at all.
Right.
But the caregiver is.
The caregiver, and that caregiver's burden is real, and it does take a village, in this case, to identify as many local supports, know your community, and introduce the caregiver to that community of supports that is available. It is by no means exhaustive or extensive, that can help in every way possible, but know your community. For example, in DC, the Village Movement, for example, volunteer-based organizations in the area that you're living in, introduce the caregiver to those supports because they will need them. They do need a lot of help. Ask your patient's caregiver about their caregiver burden. Do they have supports for themselves? Do they have people they can rely on? I have patients who range from some caregivers who have created these extensive schedules for extended family members. So-and-so is going to be with grandpa on the 29th of January from 6 o'clock in the morning till 7 o'clock until the caregiver gets back. So to the other side, where I am struggling at all times to find a caregiver for somebody who's working and taking care of a loved one with dementia. So
right. Yeah, and so your local area agency on aging is a resource for people, as well as the Alzheimer's Association, and they have local and state chapters. So, well, thank you for being with me today to talk about the 4M's framework and mentation considerations that we need to be aware of as we move towards widespread age-friendly health systems. Please check out the overview, age-friendly Health Systems podcast with Drs. Alice Bonner and also one with Terry Fulmer, and the other podcast on the other 4M's around what matters, medication, and mobility. So thank you very much, Dr. Lodhi.
Thank you.
Thank you for joining us for this special series of This is Getting Old, sponsored by the 2020 George Washington University's University Seminar Series. Towards Age Friendly is brought to you by Melissa B., PhD, in collaboration with GW Center for Aging, Health, and Humanities.